Okay, let's start.
Yes, Ishwari.
A very good evening to everyone present here today. The Manusmriti Chair and Division of Medical Humanities and the Gosumek Alumni Association, under the patronage of our respected Dean, Dr. Sangeeta Rawat, welcome one and all to the Manusmriti Oration 2023. Manusmriti is an oration conducted annually in the fond memory of Dr. M.V.L.Kothari, sir. Dr. Manu Kothari was a learned scholar, committed academician, a beloved teacher, medical philosopher, and an author of many books which have been translated to multiple languages. He worked for the institution right from the day of joining as a student until his passing at the age of 79 on 16th October 2014. He is highly respected among students, teachers, and the medical fraternity nationally and internationally. He was a friend, philosopher, and guide to all, the teaching and non-teaching staff, as well as students. I would now like to present a short video clip of Dr. M.V.L.Kothari, sir.
I was delighted to find that the word doctor comes from Dig is Disha. Dig Darshak is the one who shows the path. So Dig Darshak becomes director, becomes doctor. Therefore the word doctor is Sanskrit. Then you go further. The word nurse comes from Sneha. Sneha, nourishment, nurture, nurse. Therefore the very profession of nursing is rooted in love. The very profession of medicine, let me tell you, should be rooted in love. I was at the instance of Swami Rangnathanandji, we were in Calcutta. And we had a big meeting on doctor-patient relationship. And the question came, why should I love my patient? Why should I love my patient? Why? And then I was reminded of Chandogya Upanishad, which said, Tat Tvam Asi, the patient is you suffering. And therefore, if you love yourself, the first thing that you must do is to love your patient. And I happened to be in Abu. There were 1,500 homeopaths, and we had to discuss doctor-patient relationship. I happened to be the last speaker. There was very little time left. So I was inspired to sing, which I shall sing before you, which carries the essence of doctor-patient relationship, which we have to bear in mind. I have Dr. Parikh here, and he bears me out that Dr. Ambrose Pare, in the 16th century, he gave a great quotation, I dressed the wound, God healed the wound. I dressed the wound, God healed the wound. So God there. Until today, on wound healing, we know nothing except the fact that God heals the wound. So allow me to sing for you, and I'm sure you can join. Mariz means a patient. Mariz ki muskarahaton pe ho nisar, मरीज का दर्द मिल सके तो ले उधार, मरीज के वास्ते हो तेरे दिल में प्यार, डॉक्टर इसी का नाम है. We doctors are expected to be well dressed, but never too well dressed, because it intimidates the patient. There is a conversation in New England Journal of Medicine where a patient tells the doctor, Doctor, I am afraid of you because you are too well dressed for me. So we are supposed to be voluntarily poor. माना डॉक्टर देखने में फकीर है, फिर भी यारो दिल के वो अमीर है. माना डॉक्टर देखने में फकीर है, फिर भी यारो दिल के वो अमीर है. मिटे मरीज के लिए वो जिंदगी, करे मरीज के लिए वो बंदगी. किसी को हो न हो हमें है एतबार, डॉक्टर इसी का नाम है. A patient comes to us not by walking, not in car, not on cycle, but on a path of faith. A patient comes faith. Faith. रिश्ता है मरीज के एतबार का, जिंदा है तबीब से नाम प्यार का. You know one thing I tell you, somebody in distress, you look at the person as your own, and if love is dripping from your eyes, much of the patient's illness is likely to be mitigated. We must look at the patient. It's I who am suffering. It's I. It's incidentally. In fact, in Quran it is said that before a doctor goes to a patient, he must thank the God that but for your mathematics, I could be there and the patient could be here. Please remember. रिश्ता है मरीज के एतबार का, जिंदा है तबीब से नाम प्यार का, कि मर के भी मरीज को याद आएंगे, मरीज की आंसुओं में मुस्कुराएंगे, कहेगा हर मरीज मरीज से बार बार, डॉक्टर इसी का नाम है. So first thing, medical science is not an arena of being serious, of being very, no, it is an arena of laughter. And why laughter? Because it's a fraternity of co-sufferers. It's a fraternity of equality. I have patients from all over India. Obviously, they come with cancer and coronary. And the first question from an advanced case, just the last week when I was in Baroda, I went to the rural area and I saw Damji Bhai with an advanced chondrosarcoma. And Damji Bhai's wife asked me, how long will my Pati Dev live? So I said, he can attend my funeral. શું વાત કરો છો સાહેબ? મેં કીધું કે મણિબેન મરવા માટે કારણ ન હોય. Time controls death. Disease does not produce death. Even in Gita, Lord Krishna says, Kalosmi lokakshaya krutta pravruddha. He did not say rogosmi krutakshaya. Time I am designed to annihilate man. We sometimes say, Sahib kaad kari gaya. He died. Because most of us don't realize that with each breath, I first inspire, then I expire. Doctors in this house will agree. Dr. Parikh, you agree? I just now expired. I continue to talk to you because the next breath has come. I have a cutting, Jayashri Ben, from Calcutta. One Dr. Banerjee was talking on how to prevent heart attack and he collapsed and died. Most of us have an illusion that we take breath. Today Mr. Nair says, sir, will you have chai? I said no. Will you have coffee? I said no. Will you have pani? I said yes. You say no when you can say yes. You say yes when you can say no. Is there anyone in this house who will say, आज सांस लेने का मेरा mood नहीं? Today I am not in a mood to take breath. Moral of the story, breathing is not under your control. And when you go to sleep, who breathes for you? Supposing this task had to be shared, you tell your wife, I am going to sleep, you breathe on my behalf. And then she sees, Kaun banega crorepati, and forget to breathe for you. We hardly realize that you have control on half the breath, not even full the breath. I know that the air which has come in will go out. I do not know whether the air which has gone out will come back or not. Personally, I feel for a good life, to realize the kshanabhangurta of this body is the most important philosophical stake you can take, because I don't like to get angry because I don't know whether the next breath I will be there or not. And Robert Louis Stevenson in East Triplex, he writes, life is briefer than the flicker of a matchstick. Life is briefer than the flicker of a mist. Abhi tha, abhi gaya. And look at Sanskrit dictionary. The word deha comes from Dahan Yogya iti Deha. You can confirm it in a dictionary. Dahan Yogya iti Deha. Dafan Yogya iti Deha. And the word Sharira comes from Kshayate iti Kshariram. This is in Raghuvans. One that ages every moment is Sharira. And significantly, Ashwarya Rai is abbreviated as nothing but Ash and Rakh, which is her destiny.
Dr. M.V.L.Kothari was a learned scholar.
And therefore, a country which realizes that this body is supposed to gray does not go after beauty parlors. We are creating a nation of neurotic people. Kala idhar, gora idhar. Tragedy. We don't meet the person, we meet the dye. So I sometimes say that people who are worried about their gray hair have to dye every day.
Students, teachers, medical fraternity,
and about a person coming out of beauty parlor, there was something very well written at the back of a truck. देखने में कितनी हसीन हो मगर अंदर से बिगड़ी हुई मशीन हो. With this preamble, ladies and gentlemen, let us come to so-called illnesses. I was delighted.
Thank you, Badal sir. Dr. Manu Kothari has left behind countless students who cherish the memories of their association with him and are grateful for the profound impact that his thoughts and behavior had on them. Thus, members of the medical fraternity desired to institute a chair of medical philosophy in his name to nurture sir's philosophy of life. Dr. Manu V.L.Kothari Chair of Medical Humanities was instituted at St. G.S. Medical College on 23rd January 2016. World-renowned ethicist and a former professor and head of Department of Neurosurgery, Dr. Sunil Pandya, is the Manu V.L.Kothari Chair of Medical Humanities. Dr. Ravi Ramakantan, former professor and head of Department of Radiology and one of the founders of this division, is here with us today. Sir, I kindly request you to say a few words.
Okay, I thought I was just supposed to introduce Philip. The speaker, do you want me to do something more? And then Philip doesn't get a chance to speak. Take a chance. I think I'll just introduce Philip a little bit because I've spoken about this so many times. And Padmaja and you don't mind because we can carry on with the program. Let me say a few words about Philip. Philip and I go back a long way, and we came to the medical school perhaps on the same day in 1971. So I know Philip Abraham fairly well. I'll keep it short. Philip speaks seldom. He speaks softly. And in those seldom spoken soft words, he says a whole lot. This evening, for the next half an hour, 45 minutes, listen to him carefully. Because besides serious stuff, there will be jokes and there will be puns, and you will see no change in the expression of Philip's face. He talks profoundly simple things in simply profound ways. Philip, all yours.
Thank you, Ravi. You made my job a little difficult because I thought an oration was a serious matter. So I have taken off all the jokes out of this, but we'll meet separately to celebrate those occasions. Can I share my slide now? Are the slides visible now?
Yes,
you can see the slide here.
Yes, sir.
Okay, so let me proceed with this now. The Dean, St. G.S. Medical College and KM Hostel, my alma mater. As Ravi said, we spent from 1970 onwards so many decades of our life in this institution. And in fact, I was on the faculty from 1980 to 2010, a total of 30 years or so, and we were students before that. So about 40 years of our life was spent in this prestigious institution, and I can never forget those days. the Gosumek Alumni Association, the Dr. M.V.L.Kothari Chair, and the Division of Medical Humanities, my profound thank you, my sincere thank you for having invited me to deliver this oration. I realize that this is a prestige that has been bestowed to several honorable members before me. So I do hope I can fit into the shoes that they have set out in front of me. And I'm sure the ones who follow in the years ahead will do a better job than I do. I don't know if I need to mention Kothari sir anymore, because we've had a clip from this just a little time ago. We all accept and we all acknowledge that he has been an inspiring teacher. Everything that I remember from my anatomy, and my surgery colleagues remember much more than I do, but everything that I remember from my anatomy can be traced back in the years to some anecdote that Dr. Kothari taught us. At that time, he was young and we were kids, but he was always an inspiring teacher. As you just heard, a master of the language with amazing oratorial skills and a phenomenal memory. You could see how he could recite not just limericks, but poems and songs in English, in Hindi, in Gujarati. But above all, what I liked most about him, because that's what saw us through the subsequent years after we finished anatomy, after we finished our graduate days, my recollection of Sir was his personal touch. Every time we went to him, he would treat us like he was or we were his colleagues, long forgetting the fact that we were his students, to the extent that while he was a friend to all, I remember that he called me Lord Abraham. I still don't know why he did that, but he always referred to me as Lord Abraham. Until the last day, I know that he used to remember the names of my wife, my daughter, my son, like it was just yesterday, and that he was so close to us. The fact is, he lived just 2 or 3 buildings away from where we live, but that was not the reason why. His memory was phenomenal, and you could see that in the clip that we just saw. Then, of course, the Lopa ma'am that I know, I don't have to mention more about her, always approachable, always helpful. And I know that when my children were in their medical school, ma'am came forward and helped us in various ways in teaching them and just reaching out and making life so comfortable for them. As you all know, she has a kind, comforting, and soothing hand, most importantly, selfless. She never craved for position or power, but was deeply involved in everything that she undertook. And you can see the result of that in all the orations and the several activities that this prestigious institution has always had. Going back to our days and our graduate days, I humbly dedicate this oration to all the noble teachers who made this batch, of which Ravi and I are members, the 71 batch, a memorable batch. We always think of these as a batch that was unique. And so I speak on behalf of my batchmates who gave me the best years of my life. And I'm sure that they carry high the standards wherever in the world they have been. At this time, I cannot forget the fact that we've lost some of our batchmates. And so I bow humbly in tribute to them, those who have left us for happier shores. God bless their soul. Maybe someday we will all get together, Ravi, and maybe we'll be at the Katta once again. So I'm going to talk for the next few minutes on the practice of medicine, more so on the evolution of medicine. And as I mentioned earlier, what we're going to talk about is, and Sir touched on that in his talk before this, is the practice of medicine, the science and art, neither or both. As we know, many professions are practiced as art or as science, and I'll give you a few examples. Education. We all know our high school teachers, and more so our junior school teachers, as the one who had a finger raised and who had a ruler in one hand and a chalk in the other, and enforced discipline among us. That was the science. He or she taught us a subject, and that was it. On the other hand, there's a person who is known or is synonymous with education, who taught us the art of education, the broader picture, the overall overview or a bird's eye view of the field of education. Similarly, politics also has been practiced as a science, as you can see. I'm not sure it got anywhere, but this was it. Politics as a science. And on the other hand, we have politics being practiced as an art, and you know the success story behind that. So if you can have science, if you can have education, if you can have politics being practiced as art or science, why not medicine? Why should medicine be an exception? So I'll talk about my perspective on perspectives on medicine. I'm not sure that everybody agrees with it. And like I mentioned earlier, the evolution of my thinking on the perspectives of medicine has evolved with time. From the day I joined as an undergraduate student to the day I graduated and then went into practice, and now decades later, when I'm old, not necessarily more mature, but my thinking about the perspectives of medicine have evolved with time. And while I've divided this into two parts, medicine as a science and medicine as art, you can see that even the idea about medicine as science has gone from pure medicine or pure science to applied science. And we'll take that a little bit one by one. So let's look at medicine as science or a pure science. Now, what is cookbook medicine? All of us know about that when you read from a cookbook and you're experimenting in the kitchen, you don't want to waver from what's written in the book. So you follow everything to the T. You look at the book at every step, or nowadays look at the video at every step and bake your cake or make your favorite vegetables or whatever. But that's cookbook medicine. There's no wavering from what is mentioned there. So we look at cookbook medicine either as evidence-based, and I use this term synonymously with clinical evidence-based, or what we call clinically oriented medicine, or technologically oriented medicine. So when I talk about evidence-based medicine, I'm talking more about the clinical orientation. So when you look at medicine as pure science, what is the evidence? What's the argument to say that it is a pure science? What is the logic behind calling it a pure science? And that is to say that there is only one way to treat a patient. That is a scientific way, very simple. And in the olden days, like when we were undergraduate students, our teachers moved away from the standard teaching and used their thinking, their lateral thinking, to innovate or experiment or even try new forms of therapy in different patients. But today's students will think of that as the variations in care delivery, as the relics of the time before we had sophisticated information technologies and advanced diagnostic tools. Now that we have that, we don't have to waver. There's no thinking, there's no lateral thinking. It's all there in PubMed, it's all there in Google, and that's it. That's medicine as a pure science. And where medicine has reached today is based on research and scientific evidence. And so it shapes the guidelines that we have to improve clinical outcomes. Very straightforward argument saying this is a pure science. I'll give you examples of why it can be called a pure science, or what's the evidence-based medicine. Like I said, there's only one way to treat a patient. There's no thinking about that. I'll give an example. It's also clear to us. When you cut off the blood supply to the brain, you know that each passing second or each passing minute is important and can lead to permanent impairment or death. So the American Stroke Association and the AHA have published standards for testing and how quickly we should treat. And evidence shows that if you follow these guidelines, you can prevent or lower the rates of in-hospital death. On the other hand, doctors who think differently or who think they can think differently in implementing these guidelines don't fare so well. Another example, by giving beta blockers, ACE inhibitors, aspirins, statins to a patient with a heart attack, you can substantially reduce the risk of cardiovascular events. So once again, the American Heart Association has given us guidelines about how to reduce such risk. And we know from the evidence that institutions or regions that use their intuition to waver from the guidelines have actually made patients suffer. So these are firm guidelines. Medicine as a pure science, there's no thinking away from that. A third example, we know that this is a report that's more than 2 decades old, but close to 100,000 people at that time died in hospitals because of what we call preventable medical errors. So a joint commission published guidelines and verification processes to help prevent such errors. And when physicians, particularly surgeons, adhered to this protocol in the theater, medical errors dropped from 1.5% to less than half that. And physicians or institutions that did not subscribe to these approaches had their patients suffer. So there it is, evidence-based, everything is black or white, there's no thinking. I'll give an example about one of my colleagues or my contemporaries who was in Tata Memorial Hospital when I was heading the Department of Gastroenterology at KM Hospital. He used to come over to teach our students and bring his students along, and we had joint meetings. And one of the favorite questions that this friend of mine used to ask is, what is the evidence? Let's say 1998 is when he was with us. What is the evidence in 1998? Where are the data to support it? So what are the current guidelines? Precise answer. So you are up to date. You know what is the guideline. You know what is the data on which it is based. So you should know what is our stand in this particular age, or this particular year rather. So there it is. Pure science, you should know where we are today. But that brings a contrary thought to my mind. What does it mean? That does it mean that in 1997 and 1999, the evidence may change, our guidelines may change, our database may change? So does it mean that these evidences are for keeps? Does it mean that these are permanent evidences, or are these absolute truths? Or if it's going to change from year to year, what is the point calling it this year's guideline when you know next year's guideline may be different? So this was a different take that we had when somebody talked about evidence-based medicine. In fact, it's still everybody's darling term, everybody's catchphrase, EBM. If you don't have the evidence, you have no reason to do that. So we still, or many schools still consider medicine as a pure science. Let's take a look at these. Are evidence-based medical truths absolute? Is there no moving away from that? We know that when we started our medical career many decades ago, we know that low cholesterol is protective. So there was a cutoff of 250 milligrams per deciliter at that time. Over the years, and I don't know what drove the cardiologist to do that, over the years, the cutoff line went from 250 to 200 to 150 to even 100. And now I think they've gone back. The thinking at that time was less, the better. Even less, even better. But where was the truth then? If the truth at that time was 250 and the truth now is 150, what is the absolute truth? Let's take another example. We've all learned that the standard BP, blood pressure in individuals, is 120/80. But for those of us who have done our internship in the rural areas, we know that the average healthy rural Indian has a BP lower than that. So when you go to a doctor and you say that you've got giddiness, or you're just feeling weak, or you have fatigue, and he records your BP as 100/70, technically you have low BP. But we know that these are people who are working in the farms who have a BP of 100/70 or 90/60. So what is the truth in this evidence? Or we all know that vitamin D levels in our lab reports says below 20 is low, 20 to 30 is insufficient. But in clinical practice, when we see an individual who has a value above 30, the first question we ask him is, are you taking any supplements? That means most Indians, despite all the sunshine exposure that we have, do not have values above 30. So what is the truth then? Are all Indians ill, or is 30 only an artificial figure that should go by? The PSA levels, as we know, prostate-specific antigen, the US FDA had implemented that as a screening test for people above the age of 60, if I'm not wrong. 2 years, 3 years of this being used as a screening test for prostate cancer. And last year, the US FDA took it off. So what is the truth? That was based on evidence, and this is based on evidence. So which evidence is the absolute truth? Or we attribute all sore throats to either allergy or viral infections, although all good Indian doctors will prescribe an antibiotic for allergies as well. But if you look at the DNA sequencing data on these throats, you'll realize that all of them are not viral. There are other organisms that can give rise to the same symptom. So the evidence that we have that this is viral is based on archaic testing methods. And more advanced methods tell us that this is not always viral. So what is the truth? Again, nitrates, we used them liberally in the 60s and 70s. And then came a time in the 1980s when we said that nitrates can cause coronary steal syndrome. So they were taken off. No cardiologist ever mentioned nitrates. And now they're back in fashion. Where's the truth? Chloramphenicol, one of the drugs that we used to use as a magic pill for what was then referred to only as typhoid fever or paratyphy, was used as a rescue medication for every patient with enteric fever. But 1 in 20,000 individuals may develop aplastic anemia. So it was taken off, banished like it was a crime to use chloramphenicol. Now every ID specialist would use this drug when it is appropriate. Who's right? We now have ultrasound being done in every individual who goes for a health check. Our teachers used to tell us that you have to be, or patients have to be 40, fat, fertile, female to run a high risk of getting gallstones. Now we know that the slim male in his 20s also can have incidental gallstones on ultrasound. We see it left and right. We see it rampantly all over the place with individuals coming to us with incidentally detected gallstones. What do we do with this? The natural history of gallstone disease tells us that the chance of his developing a complication from gallstones is 20% in a lifetime. We don't know who's in the 20, who's in the 80. So the surgeon says, why can't I just operate on these patients? My risk from surgery is less than 0.5% or 0.1% if you look at the major consequences. So what do? Do we allow this individual to take a 20% chance that the gallstone will affect him through his life? Or do we just put him under the surgeon's scalpel and say 0.1% risk, why don't you just get rid of the gallstone or get rid of the gallbladder? So what is the truth? So there are no evidence-based medical truths on one side alone. There's a black and a white and there's evidence on both sides. Do we then consider medicine as pure science? Technology came to our rescue. I must make a mention about that. Technology changed. Now we're not talking about clinical evidence base for our practice of medicine. Ravi will remember that our generation has been privileged because we've seen the explosion of technology in the brief careers that we've had in medical school and later. We have witnessed the evolution from evidence-based or clinical medicine to technology-based medicine, to machine learning, to artificial intelligence. And my generation, I believe, still retains its natural intelligence or its clinical sense despite being exposed to technology. Ravi will recollect that when we were students, in fact, up to the time that I was an associate professor, we had to bank on the clerical staff to use the Remington or the Godrej or whichever, the manual typewriter. Electric typewriter also was not available to us in KM Hospital. Where have we come in the next 30 years? Our department, that's the Department of Gastroenterology, along with the Department of Neurosurgery, was the very first in the KM Hospital to get a PC. This was in 1987 from the proceeds of a fund that late Dr. Ajita Mehta had conducted a conference for this. And from that, the funds that we derived or we bought the first PC in KM Hospital. What was the disk capacity of that PC? 20 MB. Huge. Today, that's the kind of thing that you have on a small chip on your fingertips, right? So in our time, we've seen it going from manual typewriter to the PC, to the laptop, and finally to the iPad or its equivalent. When we were students, when we were residents, when we were lecturers, we didn't even have a telephone in the wards. The few landline telephones that we had were spaced out, one per floor. And now we have all kinds of phone available, even with the man who's cleaning the patient. We started our career with rigid sigmoidoscopes. We call them rods, or some of them call them bamboo sticks. It was quite criminal to the patient, quite cruel to the patient. Today, we can do without even putting an endoscope into the individual. We just make them swallow a capsule and you get all the information that you want from the intestine. We had, and we were dependent on Ravi to give us that, the II, that is the image intensifier or the plain X-ray machine. That's where we all grew up. We stuck needles into liver abscesses based on our clinical sense. There was no ultrasound. X-ray would not image the liver. So what would we do? Our seniors would say, just stick a needle here and you'll get it. There was no prothrombin time. There was no INR. Then came ultrasound. Then came CT scans. Then came MRIs, and it goes on and on from there. So now we are saying that medicine is a precise science. Technology will show us what the human mind cannot see or what the human eye cannot see. Wonderful. So technology-made medicine is so good. It has advanced so much that one of the former governors in the US said, I think we're rapidly approaching the day where medical science can keep people alive in the hospitals. Famous words, and we'll come to the rest of his sentence as we go on. So technology has made a big difference, and medicine, the practice of medicine has now become a much more precise science. So we say, we can see that. These are data from India. When we started our career, the average life expectancy was 48 years. We're not talking about the city of Bombay at that time. We're talking about rural India as well. The average Indian lifespan was 48 years. Today, it's more than 70 years. In a matter of 50 years, it's almost double, or at least gone up by 50 to 70%. Technology has made the difference to the extent that the progress has been so good that the bottom of the chart shows us that the percentage change is now dropping. There's a limit. We may not live up to 100, we may not live up to 120, like Professor Kothari mentioned. So the process of change is now decreasing because technology has not reached its pinnacle. That's what technology can do. Finally, medicine as a magical science. It says that formerly when religion was strong and science was weak, men mistook magic for medicine. Today, science is strong and religion is weak, so men mistake medicine for magic. So we expect from doctors that from their evidence-based medicine, when they've gone to technology-based medicine, that now doctors can do magic. Come to the applied sciences. We talked about the clinical science or pure science based on evidence, that's clinical evidence, and technology. Let's see then if there is no absolute truth in basic sciences or in the practice of pure science as medicine, can applied science make a difference? Why applied science? Because we just learned that there is no black and white in the books. There's only shades of gray. So we look at application of the knowledge that we picked up from this so-called pure science. What is applied science? It is nothing but the application of pure science to a particular class of problems. Famous words. But no one can apply science unless he has a firm grasp of the principles of science. That means you should know the principles of science as pure science before we can apply that and call it applied science. Not anyone with ignorance can do that. We say, oh, this is an article that came in the NEJM several decades ago. It says that medical practice depends on generalizations that can be applied and scientifically demonstrated. So there again, we are talking about evidence. Even when we apply from the pure science, we're talking about evidence. It says that medical practice is not itself science. It is based on science or training that is supposed to teach doctors to apply scientific knowledge to people in a rational way. That means it's not pure science. It's not clinical evidence. It's not technology alone. You must apply your mind as to how to use that technology, how to use that clinical information in treating your patients. So you can see the evolution. We've gone from simple clinical-based medicine to technology-based medicine, and now to applied medicine, where we're saying, take all the information that you can. A machine can tell you that this is the image, but you need to apply your knowledge to see what that image means. So we all are aware of what Osler said, that the good physician treats the disease, but the great physician treats the patient who has the disease. The machine will tell us, the lab will tell us what the disease is, but how to treat an individual, a suffering individual with that disease, only a great physician can do. That is applied science. We've all heard of Atul Gawande. You know about his famous book, Complications, a Surgeon's Notes on an Imperfect Science. What did he say? It says that science or medicine is an imperfect science, constantly changing knowledge, uncertain information, fallible individuals. There we are. There's no universal truth. There's no absolute truth in medicine. Goes on to say that it is habit, intuition, sometimes plain old guessing that can make a difference to a patient. We all have our wealth of knowledge. We all have the books. We all have free access to PubMed. We all know that technology can tell us what it looks like, but how to apply that needs some intuition, some plain old guessing. We're going to the times of our teachers when they didn't have access to all this technology. So, I'm sorry. There are two value-neutral truths about medicine that we need to review. One is medicine a pure science? And we just debunked that. Medicine as applied science also has universal truths. We need to look at that as well. So doctors believed in the universal truth of medicine, that it transcends all boundaries. So what is decided in Rome is applicable around the world. I'm using Rome because we have the Rome Foundation that talks about functional bowel disorders, okay? We have multinational companies that make drugs somewhere in the US and sell it in India. We have international conferences where all of us are attending and pick up messages and come back and apply it in India. The WHO is a World Health Organization, so it tells us what's applicable to the rest of the world. We have RCTs, meta-analyses, international society guidelines. All of them say that all this is universally applicable around the world. Let's take a look at that. Is it true? Is applied science also a universal truth? Here, for example, just 2 examples, the Germans consume 6 times as many heart drugs as the British do. And cardiac glycosides, apart from non-narcotic analgesics, are the second most commonly prescribed drug in this country. They have 85 drugs listed for treatment of low blood pressure. And we just talked about the definition of low blood pressure, whereas hardly anyone in the UK gets treated for low blood pressure. So who's right? They're both applying their knowledge to science. They're both using the information that they have, but you can see how different in the continent and across the channel the practice of medicine is. So who's right? This is applied science. Or, being a gastroenterologist, I'm tempted to give gastroenterology examples. H. pylori has been declared as a class 1 carcinogen by the WHO. The West says if you find an individual with Helicobacter pylori infection and he's got symptoms, you get rid of that bug. There's no thinking. All right? It can cause gastric cancer is what they say, so that's why it's a class 1 carcinogen. In India, 80 to 90% of individuals are serology positive for H. pylori. So we've all been exposed to that bug, but the incidence of gastric cancer is so low. It's the same in Africa. So we call this the Indian enigma. We call this the African enigma. So what is it? The WHO says it's a class 1 carcinogen. Treat it, chase it, get rid of it. But we don't see gastric cancers in India or in Africa. So what's the truth? Or look at it another way. We all have heard of irritable bowel syndrome. The phenotypic disease is the same in an American and in an Indian. We attribute it to gut dysbiosis. But the Indian gut is so different from the American gut as far as its microbiome spectrum is concerned. Then what gut dysbiosis are we talking about when we talk about irritable bowel syndrome? Or NASH. What's hepatitis? One of the risk factors is obesity. But then in India, we have something called lean NASH, a thin person also developing non-alcoholic steatohepatitis, fat in his liver, but not fat in the body. What do we do with such individuals? So where are we applying the knowledge that we have? Here are some examples of diagnoses that at one time raised eyebrows, then fell off the horizon, and some of them have actually come back. I've listed some of these: chronic low blood pressure, tropical enteropathy. We know that our family doctor still takes a person with his BP of 100/70 if he comes with fatigue and says, you've got low pressure, you've got chronic low pressures, and you ask him to take more salt, you ask him to take lime juice, and we say that this is the application of the knowledge that I've built up over the years. More examples: how sacrosanct are RCTs? Do we need a randomized control trial to tell us that penicillin works in meningococcal meningitis? What is the value of guidelines that are based on expert opinions, what we call level 5 recommendations? Or we know that there are formulations in India that have 52 ingredients. I don't have to mention them. There are probiotics in India that have 8 ingredients. Who decides how much of those 52 are to be put in, how much of those 8 are to be put in, or what complementary roles these 8 ingredients in that probiotic had? We don't know, but it's there and we are prescribing it. That's applied science for us. So I'm bringing back a quotation that I mentioned earlier as medicine as science. We had this former governor saying that, I think someday we're rapidly approaching the time when medical science can keep people alive in hospitals. Sounds so good, but read the rest of his sentence. It says, alive in hospitals, hooked up to tubes and things, far beyond when any kind of quality of life is left. So technology can take us this far and no further. You may prolong life, you may delay death by intervention. I know that Dr. Kothari would not have agreed with this, but you can do that. But at what cost? What happens to the quality of life when you apply technology to the practice of medicine? So finally, this topic is dear to my heart: medicine as art. The lecture that we heard from Dr. Kothari said the same thing. Medicine as a science, a pure science or an applied science, and we've seen the limitations. Now look at medicine as an art. And I'll just give you a few quotations. It is said, much more important to know what sort of patient has a disease than what sort of disease a patient has. So important. Individualization, lateral thinking. Go back to where our clinical teachers had taught us. Every individual is different. There's no pure science. You have to see that as an individual. You have to be empathetic with the patient. This is exactly what Dr. Kothari just said a few minutes ago, that think of yourself as sitting on the other side of the table and think of what that patient is carrying with him, his mental burden, his physical burden. He's come to us with a disease, not just with a diagnosis of NASH, not just with a diagnosis of GERD, but he's an individual who's suffering from that. So it is much more important to know the patient than just his disease. Every patient you see is a lesson in much more than the malady from which he suffers. A patient that you have seen 30 years ago, 30 years later, you'll remember, yes, that was something that I had seen at that time, and I think this is how he got recovered, or he recovered. I'll give you an example. Those of us who are practicing gastroenterology have come across patients almost every week who have belching as a complaint. And they say that when I press this spot here, I can belch. When I press this spot here also, I can belch. And the first time you see a patient like this, you think he's off his rocker. You'll think of this as a man who doesn't know what he's talking about. But then whether the patient is from Kashmir or Kanyakumari, he's telling you the same thing. When I press this point here, I can belch. Is this something to do with the meridians in our body? Something to do with the practice of acupuncture and acupressure in Chinese medicine? Have we missed out on something? Is the patient telling us something that we should understand? When you hear this from 50 patients, you know that there must be some truth in this. Don't dismiss this as something that is fable because you don't understand that. So listen to the patient. Every patient is a lesson to you. That's a human touch. The use of the human faculty to focus on the patient as a fellow being who has come to you seeking help for his health. I tell my residents, think of the families whose entire life revolves around there's an appointment with the patient, with the doctor. I have to cancel my other assignments. I have to cancel my other appointments. I have to cancel all the other meetings that I have because on this day I have an appointment with the doctor. So the entire life revolves around the appointment with the doctor. Understand that when he comes to you, he's not just coming as a walking disease. He's coming to you because he needs your attention to what he's suffering from. The ability to listen, to empathize, to inform, and to maintain solidarity. You don't tell him that, oh, I had the same complaint. No. You explain to him that you understand what he is going through. In your mind, it may be a minor disease, but for him, it's a major suffering. And you have to tell him that I understand what you are going through. Not that belching is not a disease. Forget it. Just get it out of your mind. Or functional abdominal pain is all in your mind. Throw it out. I caution my patients saying, if you go and tell a doctor that you've got irritable bowel syndrome, the first thought that will cross his mind is, this person is crazy, it's all in his mind. But no, you probably have an autonomic nervous system that is misbehaving. You have a target organ that is making you or sending you negative signals. Why do some people who are stressed get headaches? Why do some others sweat? Why does a third group get stomachache? They're all stressed. So there's something about that organ that is giving you a lesson. Understand that and tell the patient, you understand that. You empathize with that. I am part of the treatment for you. It's not just a question of writing medications. Like again, William Osler said, the practice of medicine is an art. It's not a trade. It's a calling, not a business. A calling in which your heart will be exercised equally with your head. You have the knowledge. You know how to apply it. But unless you treat that as a human who's come in front of you, you cannot practice science successfully. Like Paracelsus said, the art of medicine has its roots in the heart. You cannot be involved in the other person, otherwise you'll die a million deaths. But you should understand and stand for a moment in his feet, in his shoes, and see what he's going through. It says, a good doctor's comforting and reassuring words are more powerful than medicines. I understand you need help. We are with you. In which other profession that we can think of do you hear such words? Much of my problem is really when I talk to you, doctor. I come to you only because I want to talk to you. I come to you not only for the medicine, the pharmacist will give me that, but when I talk to you, I feel better. Which other profession will you say, you take the decision? When you take a car to the garage and he says that this carburetor is wrong, somebody else says the clutch plate is wrong, you're not going to say, okay, you decide and do what you want. You'll want to apply your mind. It's only in medicine that the patient tells you, doctor, you take the decision for me. And he also says, doctor, you are as God to me. Don't equate yourself, don't think of yourself as God at that time, but understand that in the patient's mind, you are God. You must have that human touch. That's it. We've seen this. Just a touch, just a pat on the shoulder, and the patient is more relieved than all the page-long medicines that you can give. That is medicine as art. In which other profession can you give this kind of comfort? Here it is. I don't know who said it, but imagine if you could infuse compassion through the stethoscope. Instead of listening to the heart, we could heal it right there and then. If only the stethoscope would do that for us. That's a human touch. Not pure science, not applied science, but practicing medicine as an art. And my last word is medicine as commerce. You can see that all over the place. Society recognizes money as a final currency. It recognizes money as a mark of your success. So it says, God heals and the doctor takes a fees. We don't heal, we prescribe a medicine. We think it's appropriate for a condition, but the healing is not done by the doctor. We only collect the fees. And unfortunately, in our profession, so often you see that this aspect. This afternoon there, I had a patient who said, I'm not going back to my hometown because there the doctor feels your pulse, but his eyes are on your pocket. He wants to see how thick your purse is. These are the words a patient told me just this afternoon. So, if I may summarize, our generation, Ravi, your generation and mine is unique. We have seen the evolution in the practice of medicine from so-called evidence-based medicine or clinical medicine to technology-based medicine, including applied science. We have seen its promise, but we've also seen its limitations. It's the human touch that reigns supreme. That is the only universal fact or universal truth in what is otherwise an imprecise science. Medicine is not chemistry, it's not mathematics, it's not physics. It's closer to biology. Every human is different. And the only universal truth is the human touch that we can give. Our teachers taught us that, and we have an obligation to pass this on to the next generation. So, ladies and gentlemen, all I can say that the practice of medicine is an art and a science, not art and science, but it's not commerce. Let me end by thanking my colleagues and residents. So many of them considered me as a teacher, but every time I sat across the table and asked questions, I knew that I was learning. I was the taught. I was not the teacher. Every day is a learning experience. My family, they have stood by me and allowed me the privilege of indulging in my passion as a doctor. And they are the strong pillars who saw me through. And finally, never to deny it, the Almighty, the ultimate healer, who gave me the wings to fly. Thank you once again for giving me this great, great privilege.
Thank you, sir.
very much, sir. Thanks a lot for giving us the most important messages about maintaining solidarity with the patient is one of the most important steps in treating and healing the patient. And secondly, every patient, you see, is a lesson in much more than a malady from which he suffers. I think if we took home these very important critical messages that medicine is not only pure science, but it also is an art in healing the fellow human being. Thanks a lot, sir. Thank you very much. I would like to, on behalf of Medical Humanities Division, on behalf of the chair of MVLK, I would like to offer you, sir, this plaque, which said GS Medical College and KEM Hospital, Dr. M.V.L.Kothari, Chair and Division of Medical Humanities. Manusmriti Oration is delivered by Dr. Philip Abraham, entitled The Practice of Medicine, Science, Art, or Both, on October the 21st, 2023. Signed, Dr. Sangeeta Rawat, the Dean. Thank you so much, sir.
Thank you again.
Now comes the last part of thanking, giving the vote of thanks. So again, I thank Dr. Philip Abraham for taking time out from his busy practice and delivering this oration. Dr. Sunil Pandya sir for forever guiding us as chair of MVLK. Our Dean, Dr. Sangeeta Rawat, and Dr. Harish Pathak, additional, academic Dean, for guiding us in all our endeavors. Dr. Lopa Madam and Dr. Ravi sir for being there for anything that the team of medical humanities needs. Dr. Kothari's family, Dr. Snehal Kothari, and all sir's friends for their generosity in establishing this chair. All my colleagues and dear student wing who have been part of all these activities and who have taken this whole program ahead. I also thank Badal, Tushar, Deepika, and Pranali, who have been our technology team and administrators. And lastly, thanking all the participants for attending today. Thank you all very much. And good night. We declare the session over.
Thank you again. Good
Thank
night.
you.
Have a wonderful weekend.
Good night, sir.
Good night.
Thank you all.